Our next expert speaker on the topic of end-of-life counseling is Mac Herring. Mac is a hospice nurse and is also an elected official for the town of Mooresville. So, Mac, I would just like to ask you your thoughts on end-of-life counseling, where we've been, where we're headed, and what we can do to enhance compliance with, to be sure that end-of-life counseling is provided for individuals.
The most important thing is the conversation. It's not a one-time conversation. In North Carolina, we've got tools that allow us to start this conversation. We've got our healthcare power of attorney. We've got our advanced directives. They are 2 forms that you can have completed. You fill them out, and they become your surrogate. So that your family members, your partner, your spouse can make decisions for you in your behalf should you not be able to do so. Every adult, 18 and older, needs to have these documents in place. But all they are is a surrogate for your ability to state your case if a decision needs to be made on your behalf. They do not affect what happens after your life is over, only how you're handled. In North Carolina, though, we were the 6th or the 7th state out of 26 states that currently use the POST paradigm, which is the physician orders for life-sustaining treatment. In North Carolina, we call it MOST, M-O-S-T, medical orders for scope of treatment. With these orders, it's your living will in a nutshell. It's where your physician can sit down with you, or a nurse practitioner, or a physician's assistant, and discuss what your options are. And you can list whether you want full scope of treatment or very little at all. In North Carolina, we're very familiar with the do not resuscitate order. Well, the MOST takes it further. Do you want somebody to attempt resuscitation? Because the older you get, resuscitation usually is not a viable option. You do not return to the same level of function you would think that you would. So many folks in nursing homes at end of life, their families had not had these conversations, and they wrestle and they grieve over the decisions that they've made because they didn't discuss those choices. These conversations are very important. Once a year, around tax day, is National Healthcare Decision Day. It's a time we remind folks to have that conversation when there's not a crisis, to discuss with your family members what your options are, what you want, what you don't want, and those things change. That's why it's an ongoing conversation. You do not get these documents completed and then never go back to them. It's an ongoing conversation. But in North Carolina, with the MOST orders, you've got the ability to discuss with your physician what your wishes are, and they're converted to physician's orders. That way, especially for folks who are frequent flyers to hospitals towards end of life, those in nursing homes, assisted livings, those with chronic illnesses such as congestive heart failure, cancer with repeat hospitalizations, have thought through that process. And a hospital knows when somebody comes in, these are the wishes, and this is what we need to follow, because the living will has been turned into orders. It has to be renewed annually. It's an ongoing conversation that physicians need to have with their patients. And we need a mechanism in place to do that.
So how do you think that we could, as a state and even from a national perspective, encourage and get better compliance with these forms, the MOST forms?
I think there are 2 ways to approach it, or 3 actually. First of all, those of us who utilize the healthcare system, we as consumers need to ask our physicians. We need to demand of our physicians that they have these conversations with us. We need to push the issue. We need to push the issue for our parents or our spouses. This is what we want. This is what we don't want. We need to drive that from the consumer level, and the hospice organizations across the state are doing that. And we're driving the conversations for MOST orders. The second level that needs to be approached is on the physician's level. Many physicians are uncomfortable addressing, I can't fix this. Physicians are used to providing hope, and very often when you reach end of life, none of us get out of here alive, and it's hard for physicians with the relationships they have with their patients to have that conversation.
Absolutely.
Very often these conversations are held in a hospital setting with a hospitalist who does not know the patient, can look very objectively at this is what's going on, this is what I recommend, this is where the hospice referrals are often made, whereas a primary care physician who could have addressed it, perhaps should have addressed it, is uncomfortable having that conversation. The third approach to driving this effort forward is regulatory. And I think more and more as you look at the constraints on Medicare and on Medicaid and on the waste and futility of dollars being spent for treatments that have no real tangible results, you're going to see regulatory processes put in place to make sure that these conversations are addressed. Not to ever take away somebody's right or ability to say this is what I want or this is what I don't want, but certainly to not force the hospitals in this litigious society to have to do everything until they hear otherwise.
Absolutely. I think that that's a great point, particularly the last one that you made. It is the responsibility of regulatory and professional organizations to continue their efforts with this as well.
Currently, there are 26 states with most or pulsed sets of orders. It's in works in other states. I'm proud to say that North Carolina was the sixth to adopt this in 2007. It is law in North Carolina. So if somebody has these pink most orders, hospitals, physicians are obligated to follow these orders. EMSs, the goal is to educate now across the state and get people to use it.
Great. You mentioned education. One last component that's important for this interview is that this is November. I should say November is the National Hospice and Palliative Care.
It is National Hospice and Palliative Care Month. It is a time to sit back and realize that we all have a right to quality end-of-life care, and that there are many organizations across the state, throughout the country, and around the world that provide quality end-of-life care. We have a right to death with dignity, and we have a right to our own choices. And these advanced directives are what broker the opportunity for us to do that.
Thank you so much.
You're welcome.